So I'll talk about magnetic resonance imaging, specifically in the setting of plaque in the aorta and the carotid. And one of the advantages of this technique is truly non-invasive. There's no ionizing radiation that's being applied here at all. It is not a whole body technique, so it's a whole body technique, no acoustic window limitation. It's not operator dependent, so it's not a probe of ultrasound, whatever that you're trying to do here, that you can move around. In vivo spatial resolution that's very high. And as I will demonstrate here, that it's really a technique that measures specifically the plaque. It's not looking at only one part of the plaque, like intima to media. It's not only looking at only calciums. It's really looking at the burden of the disease, as will be described to you and discussed earlier by Dr. Fuster. So one of the most important things also of the technique is the reproducibility of the methodology, because obviously putting it in the setting of subclinical disease and repeat study, it's very important that you can do this, and you do this with a lot of accuracy, with measurement of volume of area around less than 5%. And this can be done in both the carotid and the aorta, as I just mentioned. And what's also very important and critical is that the exam can be performed in a fast fashion, and they also can be combined with other measures of clinical importance, such as shown here, which this is a 3D angiogram done with very simply, is performed thousands of these on a weekly basis in the United States and in the world. You can get the percent stenosis very accurately, but on top of that you can add the vessel wall imaging, where you can look at specifically at the wall itself. So combining these two together provides really a lot of information from the stenosis point of view, especially in the carotid is obviously very important, but also on top of it you can do the vessel wall itself. And I'll just make a little comment here on time, because one of the things that always is mentioned that, oh, MRI takes a lot of time to do, is actually not true. We're not talking about looking at cardiac function here, where you have to do this over the cardiac cycle. You average over multiple cardiac, and it takes more than 20 to whatever an hour to do this exam. If we're looking at measuring, I'm showing you here an example. If you're trying to cover, for example, look at this, covering here from the top subclavian here all the way down of the aorta and in a longitudinal kind of axis. This is something that's obtained actually in less than a minute. And if you want to combine this with cross-sectional images to obtain volume, quantitative volume of plaque, you can obtain 12 sizes in less than 3 minutes. So the whole thing can be done in 15 minutes, including the preparation of the patient, etc. So really you have to look at this very critically and not just brush it off saying, oh, well, you know, it's complicated and it takes a lot of time to do. I mean, especially with recent advances of imaging, that a lot of the stuff you may be seeing in the literature, you know, that we publish or others have published, you know, a few years ago, 5 years ago, now we can do this 10 times faster. It didn't stop there and will not stop there. One other thing I just want to share to you, this is recent data, and I have here the privilege to have Dr. John Posley, who has been one of our biggest, helper in performing this study, and we collaborate with him in New York. And one of the studies that we're doing a lot of work with him from his patient population, bringing them to MRI at Mount Sinai. One of the things that we have done is trying to look at the measurement obtained by intima media thickness and comparing this to what can be obtained with MRI. So as you're very familiar with IMT, you can have automated edge detection and measuring the borders of the wall from the intima to the media. The MRI is slightly different. It actually provides more information because you're measuring the whole plaque, looking from the inner wall all the way out to the outer wall, including the adventitia. So you're really looking at the whole burden of the disease, and you can actually measure this in both ways, in a longitudinal fashion and also in a cross-sectional fashion, as I mentioned here. And this can be traced also automatically. So one of the things that we've done a lot of things, but just one of the pieces of data is looking at the maximum intima thickness and some of the correlation that we find with, for example, a wall carotid area. And measurement here. You can see that there's a correlation between the two, but with MRI, we're providing additional information because we're measuring the whole plaque itself. And that's very important because a lot of the times you may be missing the plaque itself. You know, if you're only looking at the intima media thickness and you're missing totally this wall thickness. Another point that actually Dr. Alan Taylor, who's in the audience here, always makes, because he's participated in an incredible study, several studies. One of them is the Arbiter study looking at lipid lowering, is that the intima media thickness is not something you're going to do and look at one number for this patient at time 1 and then looking at this after what happened at times 2. This is not how you would use IMT. You would use it in a sense where you're looking at grouping the patient and putting it together. So there's a limitation in this kind of measurement if we look at it from that point of view. Now I just want to mention a couple of other examples in terms of what has been done with magnetic resonance imaging. And I know of several trials, and one of them is the multi-ethnic study of atherosclerosis, which is an NHLBI-funded study, multi-center study. And one of the things that they are doing is looking at aortic measurement of atherosclerosis. And really the most important question that we have, and maybe that's why we do not appear very prominently on that slide that Mort has put out initially, is because we do not have a lot of follow-up. There's very little, because this is a new technique that we have on hand. But the MESA is going to provide this kind of work, and there's also a sub-study by the Framingham health study, heart study that also is doing similar thing. So what are the findings? This is now in a setting that you want it to be. This is a multi-center setting, looking at subclinical disease, 196 patients, 45 to 85, showing that we're not only New York and Seattle can do this, that MRI can reliably measure aortic wall thickness with very low inter-reader variability. And there's a wall thickness correlation with age, and it's interesting also with gender and in race. That's one of the importance of that study. But also that CAD risk factors such as BMI, smoking, and blood pressure independently predict aortic wall thickness. And we really await the follow-up study of MESA to show if aortic wall thickness is going to predict cardiovascular event. So we put it out on the table. We do not have that data yet. But this would be answered, and if this study like this do not get performed, we will never know the answer. Just want to describe to you, Dr. Fuster mentioned a little bit a study that we're doing at Mount Sinai, also in collaboration with Dr. Postley here. This is showing you here, we've done so far 99 patients using the exact same protocol. You can see the description of the cohort. We're looking here at intermediate. This is what you want, intermediate risk patient. And one thing that we have looked at in this is looking at describing the patient or dividing the patient into types. For example, we look at coronary artery disease patient and trying to look at differences in their 10-year risk Framingham score, which would no differences. But if you now look at specifically looking at the disease itself, and this is the power of this measurement. For example, looking at the wall area in these carotid patient, in this coronary disease patient, looking at the wall area and the carotid. Now, obviously, the group with coronary artery disease is going to have more plaque. And same thing has happened also in the aorta, that the patient with CAD have also not only plaque in the carotid, but also have plaque in the aorta. And now we can differentiate between these two subgroups. And we are doing currently analysis on stroke patient, diabetic patient, etc. So you can imagine the kind of result. And why? It's not surprising why we're finding this, because we are measuring the disease itself. We're measuring the plaque that we're seeing. And other things that you can do is obviously putting this in the setting of lipid lowering or any kind of intervention, because this is what you want to do. You want to do some kind of intervention. Mort wants everybody to go and exercise and run the marathons. So he wants to measure, before the marathon and after the marathon, what's going to happen, right? But I guess not all the patients are going to run the marathon. You're going to give them lipid-lowering drugs. And this is a study done with my colleagues in Japan, looking at lipid lowering were considered to be high at 20 milligram or atorvastatin versus 5 milligram. 20 is considered high in Japan, and that's, you have to realize this, okay? But what's interesting here is that the high dose was more effective than the lower dose, and you can measure that. And we're not saying only in question of LDL, or obviously the important thing is heart event, but we can measure that there was a decrease after 12 months of treatment in the thoracic aorta by 17%, but there was retarded progression. We could not actually see changes in the abdominal aorta. They reacted differently. So it's important to have a technique that can measure the aorta, carotid, and different areas simultaneously. Let me see what I have. Okay, I guess, because PK is here, and we're very excited about our work with the HDL-like particle. This is using a natural lipoprotein to carry the gadolinium and to target it specifically to the vessel wall itself. I know Sam Semikas is also in the audience. He's been doing also work with nuclear imaging and molecular imaging. So this is the MRI approach. And what's interesting about this, and this is now using the HDL-like particle, and that behaves like HDL itself. And you can see that with the confocal microscopy here showing cellular uptake in the macrophages. What's also interesting is that the particle by itself, which does not have any target right now, this is naturally, goes in and enhances the vessel wall at 24 hours, and after 48 hours it gets out. So it's really going in and going out, and we have ways, and you can imagine ways, we can potentially make this stick into the vessel wall and target certain epitopes. So we will be following up. J.C. Frias will be presenting this when everybody left already on Wednesday. But for the people who are here, we'll see this. Okay, so this is my 2 cents. Thank you very much.